All right, class, this is the one you've been all waiting for here. We are going to go over succinylcholine. And the reason that we use succinylcholine is because, again, we do neuromuscular blockades with this. And basically what we're doing is we're paralyzing them for a short period of time. So the good news is guys, this is a great drug, but you have got to know the ins and outs of this drug because we break the very first rule of medicine, which is do no harm when we give it. So when I say that you have to know this, you really do. You've got to know the ins and outs of this drug. If there's one that you super have to memorize, this is the one. When you're using this drug, the person is very sick, or they're going to be sick. They're very shortly going to be there. You are stopping the patient's ability to breathe, and not knowing what you're doing with succinylcholine will kill somebody, and quickly kill them. It is the reason a lot of times medical directors don't allow paramedics to perform drug-assisted intubation because they're so scared of the side effects. You're going to counteract that with you know what you're doing, and you know about the drug and how it works and why you do certain things and why you do not do certain things, okay? And that is the key thing about succinylcholine. So the other names are nectine or quelchin. Nectine is the one that you're probably going to see a lot more of. And it is pronounced succinylchlorine. But don't shorthand it, okay? This is one that you really need to know how to spell it. Succinylcholine, okay? Make sure that you spell it out. Make sure you know how to spell it. We might say sucks in the back of the truck, but again, succinylcholine is what we're talking about. And we use a short-acting depolarizing skeletal muscle relaxant. And what we use it for is to facilitate endotracheal intubation. Those are the big words for saying that it paralyzes somebody and lets us put a tube between their vocal cords, okay? They don't get to move for 5 to 10 minutes after you give this drug, probably more around the 5-minute mark, especially if they're in a shock state. For some reason, when they're in a shock state, the drugs wear off usually a lot faster. So it's a depolarizing paralytic, okay? So and I'm going to go into that more when I go into the vecuronium video, but essentially it causes the receptor sites to actually depolarize, okay? So they cannot fire, all right? And it takes about 5 minutes for that system to reset. Again, the good news about that is that if something goes wrong during the drug-assisted intubation, we can bag them through it without having to do it for an extremely long time. The non-depolarizers are usually somewhere between 30 and 45 minutes, depending on the dose that you give. The good thing about succinylcholine is it's a 5 to 10 minutes, it's wore off. So again, 200 milligrams of succinylcholine will make all problems stop, I assure you. So again, it prolongs the neuromuscular transmission and thereby causing a skeletal muscle relaxation, and it causes paralysis. One other point about that, it causes paralysis. It does not cause sedation. So the patient, if you don't sedate the patient, they know that they are paralyzed. And that is a horrific sensation, okay? So we're going to talk a lot about that when we actually do the RSI procedure. You absolutely have to sedate before you paralyze somebody. Period, exclamation point. There is no breaking that rule. So again, it competes with acetylcholine. That's how it works at the end of the motor plates, which is causing depolarization. And at that point, it can't retransmit because the acetylcholine's not resetting it. And that's why, again, it paralyzes the person. It does relax the jaw and the eyelids. So it starts in the eyelids and the jaw, progresses to the limbs, and then finally to the diaphragm and the intercostal muscles. So, in matter of fact, we call that fasciculations. We actually see the body kind of, for lack of a better term, kind of like rattle and shake just a smidge. Just a little bit. And then they go completely flaccid. It has no effects on consciousness. It has no effect on pain. And it does not stop a seizure, okay? So you can still have neurological activity even though you have paralyzed the brain. It takes about 1 to 2 minutes to get through the system, Okay, so on the onset's about 1 to 2 minutes. Well, my experience is probably around the 1 minute mark, and it usually lasts between 5 and 10 minutes. You will start to see the effects fade around the 6 minute mark. So again, it's all about, and when we talk about we actually do the procedure of drug assisted intubation, we push our sedative, and then we push our paralytic, and about a minute goes by, and then they stop breathing. And then we immediately we place the endotracheal tube. Boom, you have a nice day. And you've got 5 minutes to get the other things that you need to get done. Matter of fact, we usually, in a drug-assisted intubation, do not go to a long-acting paralytic until we are 100% sure that we have an endotracheal tube between the vocal cords and we are able to ventilate our patient. All right. So again, we use it for RSIs, again, the drug-assisted intubations, to paralyze somebody. We can temporarily terminate laryngospasms with it. It will stop the cords from vibrating. The cords, when they've closed up and shut, it will allow them to relax. Again, it does promote muscle relaxation, like completely. And then again, they used it before to help with electroconvulsive shock therapy. That's a hotel I don't really want to go to. So again, couple of things that is bad about this drug. All right, it increases intracranial pressure, especially it'll increase interocular pressures as well. So if you've got some sort of eye injury, penetrating eye injury, we want to stay away from it. Increasing intracranial pressure, by the way, again, has its own set of very bad side effects. Initial muscle fasciculations is a normal thing that actually happens, and every now and then we'll get one that gets a prolonged paralysis, or even to the point where it actually spasms the chest muscles and you can't actually have the patient breathe. It's one of the very scary things that can happen. Again, bradycardia is usually because they're hypoxic and you're not ventilating them correctly. It can cause a drop in blood pressure. It can cause some pauses in the heart muscle, but usually that recovers pretty quick. You can have a rebound hypertension with that. Again, dysrhythmias can occur, and yes, if you don't ventilate them correctly, every now and then you get a rare one that can actually cause cardiac arrest. All right. The other problem with that rigid chest wall, by the way, is it does cause bronchospasm and wheezing. And so it's one of the other side effects that we kind of worry about when we're giving succinylcholine. And again, usually we're placing an ET tube so we're able to overcome some of those side effects. But again, start thinking along that line of they've got a bronchospasm, we need to fix it. Again, it can cause a hypersalivation. It can cause a lot of vomiting. You need to, again, make sure that you address those things. Make sure you have your suction handy. The other big one that this causes is a huge shift in potassium. Okay? And this is what a lot of things that go really bad really quickly is you have that shift in the potassium that can cause a dangerous condition called malignant hyperthermia. That's one of the really bad things that can happen. Every now and then, by the way, you do have some that'll actually get an anaphylactic reaction to it. They'll start breaking out in hives. But again, that hyperkalemia, it can shoot up somebody's potassium to very dangerous levels. And if somebody has hyperkalemia, we want to stay away from it. So speaking of those contraindications, Dr. Frank will be asking you this. You need to know these without a doubt. You absolutely need to know these, okay? If the person has, or the family has a history of malignant hyperthermia, we need to ask, okay? Especially if we got somebody that's conscious that we're going to do a drug-assisted intubation on as more of a preventative or it's preventative medicine. A burned airway would be an example. Any type of penetrating eye injury, again, it increases the interocular pressure, which again can cause problems. We don't want to use it in those cases. If they have chronic paralysis of the limbs, usually they have a potassium issue. And again, we can cause problems there. Entrapment for 2 hours or longer, again, that's because of the potassium release because of that crush injury. And if we know for a fact that their potassium level is high, if their potassium level is above 5, we should not be using this drug, okay? It's going to cause a shift, and a dangerous one, in that. So if you go to the nursing home and you just happen to have, they're going to the hospital for hyperkalemia. You got to RSI them for some reason, and their potassium is 6.2. We need to stay away from succinylcholine. All right, so again, the relative is the inability to control their own airway and support ventilations with oxygen positive pressure ventilation. If they're an asthmatic, we really want to be careful with it. And again, if they've had a burn for more than 7 to 10 days, it has to do with, again, the potassium shift that's going on in the body. And again, glaucoma is another reason it increases the interocular pressure, can cause an increased intracranial pressure as well. With the inability to control the airway, I just want to kind of make a quick point about that. So if you're having problems with a difficult airway, really stop and think very hard if that's something you want to do, is paralyze it. But what happens if you paralyze it and it doesn't work? And I can't stress that one enough, because now you're stuck for 5 minutes without ventilating the patient. That is a very bad thing, okay? Again, you've got to be able to some way ventilate the patient. Remember, if you can't get them intubated and you can't ventilate them that way, about the choice you've got left is to crike them. Okay, so again, you really, that's a very difficult airway to manage, and you gotta really stop and think about this before you do it. All right, so lidocaine, procainamide, all of those drugs that are listed there, they can potentiate the effects. So sometimes that's why we use, in a roundabout way, that's part of the reason we use lidocaine ahead of succinylcholine. Diazepam can reduce the duration of the action. Okay, so that's kind of why we don't use Valium to sedate them. We use either etomidate or Versed is usually our sedation of meds of choice. Again, cardiac glycosides, they can have, so if they're on like a digitalis preparation, they can cause dysrhythmias with that. So again, look at your patient's med list if you got the moment to do so. The patient is conscious, explain what is about to happen. Good news is I'm going to put you to sleep. After I put you to sleep, we'll paralyze you. We'll put the tube between your vocal cords. Again, atropine is used in repeat doses with pediatric patients. Every now and then we have to give a second dose of succinylcholine. When we do that, though, we need to pre-medicate our pediatric patients with a dose of atropine. Remember that children their blood pressure is highly dependent on their heart rate. So we use the atropine to keep the heart rate up on these patients. And again, pre-medicating with lidocaine can blunt any increases of intracranial pressure. I'll talk more about this in lidocaine, but with the lidocaine prevents a increased intracranial pressure spike. And it doesn't actually prevent intracranial pressure. It doesn't reduce intracranial pressure. It prevents the spike of intracranial pressure that's associated with succinylcholine. Now, again, you chose poorly. Again, make sure that your airway, you can ventilate these people before you push this drug, okay? Think about it as if it goes wrong. What's going to happen if it goes wrong? And it can go wrong very quickly. All right, you got to make sure that you sedate your patient before you hit them with the paralyzing drug, all right? And then once you get them intubated, you have to watch them like a hawk, because you are the person who is ventilating that patient, not themselves. They are not ventilating anymore. You are ventilating for them, especially if you use a longer-acting paralytic, okay? Succinylcholine does promote paralysis, but it does not anything for the loss of consciousness, for the level of consciousness, or the pain. It does nothing for that, okay? So again, sedate your patient. When you start to see the patient cry or start to move, sedate them more, okay? Now, the patients with severe burn trauma, again, it's going to cause that potassium shift. I talked about that a little bit earlier. And again, brain or spinal cord injury may prolong the effects, again, because usually there's a mess up at the neuromuscular junction. That's usually why it happens. Guys, succinylcholine does not stop seizure activity. It stops the muscles from moving. It doesn't stop the neurons from firing, okay? So you're still going to have the neurons firing. It's just that the patient won't be moving. Commonly, we get 200 milligrams in a 10 ml ampule. That's kind of our standard dose when everybody sees a succinylcholine bottle. and it's usually labeled up top with a cap that says paralytic, caution. And yet, again, make sure, especially if you've got other drugs around your succinylcholine, make sure you're grabbing the right drug. I had a paramedic a couple years ago. He had the cardizem and the succinylcholine was right next to each other, and instead of pushing cardizem for the patient's tachycardia, he pushed succinylcholine. Patient stopped breathing. Good news is he was able to bag him through it. The bad news is he got 6 more months with me. Okay, now again, right dose, right patient, right time, all those things, those 5 R's that we always talk about. Our dosing. I'm of the school, I want to go big or go home, okay? So 1 to 1.5 milligrams per kilogram, I'll tell you that it's probably more like 1 to 2 milligrams per kilogram for the adult. But 1 to 1.5 is our official one, okay? So again, we're going to give it 2 to 3 milligrams per kilogram is what's given IM. You can repeat this dose 1 time only. We usually try not to go 2 doses. If I'm going to give a dose, I want to go big. If you're going to make a mistake, go big on this drug. Again, the maximum dose, by the way, is not 100 milligrams. The maximum dose is 200 milligrams. Again, it depends on the size of the patient. There's some places that say that the max dose is 100 milligrams. I've given 200 to a really big person before. It does happen. And then your pediatric dose is 1 to 2, and I would lean towards more the 2. And the reason is that kids don't have the neurological receptors like they do, and they quickly recover. So this is one that I would probably go heavier than I would lighter on your pediatric dose. So again, be thinking more the 2 milligrams per kilogram on your kids, and you can repeat once only. Matter of fact, don't repeat over 2 milligrams per kilogram. Okay. Your 2 milligrams per kilogram is probably your max dose that you really want to do. Again, way too much potassium shifting going on if you go higher than that. So you might get a second dose, and that's about it. And then pediatrics are not as sensitive to the succinylcholine. So if you're going to hit these kids, this is what I say: hit them with 2 milligrams a kilogram. Make it happen. We can give it IVP. IM takes forever to work, but I've actually seen a case where it did work. And then again, IO and IV again are the same basically things. Again, not well established, but most of the time, I think I've done it to 1 pregnant patient. We didn't have any problems with it, and again, it was a trauma case. All right, so that's succinylcholine. Again, you have to know this drug. You got to know when to give it, when not to give it. You got to know what exactly it's going to do. All right. And you got to know when not to give it. I can't stress that enough because Dr. Frank is definitely going to ask you. All right, guys, that's going to be it, and I will see you all in the next one.